Good morning, good evening, everyone. I'm Bruce Hobson, a family physician and medical director with UBC CPD, and I'm happy to welcome you to the Eating Disorders webinar with a panel of physician experts and specialists who will answer your questions tonight. I'd like to begin by acknowledging that the land on which our UBC CPD office is located is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And I'd also like to acknowledge all the lands of all the Inuit, Métis, and First Nations people on which we live, work, and play. We'd like to thank the Child and Youth Mental Health Substance Use Committee of Community of Practice, an initiative of the Shared Care Committee, a joint collaborative committee of doctors of BC and the BC government, for providing funding to support the delivery of this webinar. This is a 90-minute webinar and is the 31st in a series of COVID-19 webinars that the UBC Division of Continuing Professional Development within the Faculty of Medicine is delivering to support a multidisciplinary healthcare audience in urban and rural practice during the COVID-19 pandemic. I encourage you to participate in the questions and answers during the presentation, as this will drive most of what's being discussed tonight. We'll be using a platform called slido.com to receive your questions. So please go to www.slido.com and enter the event code COVID-April. That's COVID-APRIL, all one continuous word without spaces, which was included in your email invitation to this webinar. And please upvote the questions suggested by others if you're really interested in increasing the chances of having them answered by our panel. We will try, but may not get to all the questions in the allotted period. And if you're having any technical difficulties, please note that the webinar will be recorded and will be shared within a week, together with a link to all the resources mentioned and a summary of key pearls to everyone who registered online. And finally, at the end of this session, please remember to take a few moments to complete the attendance and evaluation forms. In order to obtain study credits, you must complete the online attendance form. You can access these forms via the email link that you received for this session. So, as the COVID-19 pandemic evolves, UBC CPD wants to especially acknowledge and really thank the thousands of faculty members, medical residents, healthcare professionals, and frontline staff who are working in extraordinarily stressful conditions in the healthcare system to provide the best care possible. I know that many of you are in the audience tonight, and if this stress is becoming overwhelming to any of you, please talk to a colleague or call for help through the Physician Health Program at 1-800-663-6729. We can't thank you enough for your efforts. This is a free webinar tonight and is being offered with that in mind. That number again is 1-800-663-6729. So let's get started with this session. I would like now to pass you over to our moderator for tonight, Dr. Susan Baer. Susan, over to you, please. Introduce yourself and take it away.
Hi, everyone. I'm very happy to be here with you this evening. As Bruce said, my name's Susan Baer. I'm a child and adolescent psychiatrist working at BC Children's Hospital, where I'm the Senior Medical Director of Outpatient Mental Health Services. I'm not an eating disorders expert, and I'm actually really looking forward to learning along with you tonight. We have got a really great set of panelists who are experts in eating disorders. And the way that the evening's going to work is the panelists are going to introduce themselves. We've got 4 panelists, 3 of whom are going to give a short didactic presentation. And then we'll be turning it over to question and answers using the Slido format, as Bruce mentioned. One note for this evening, the focus of the presentations and the questions is on eating disorders, not ARFID. And ARFID is just a very large, big topic that's really beyond the scope. So if there is interest in that, you know, please give that feedback to Bruce and the team, and potentially that could be a later topic. So without further ado, I'm going to turn over the introductions to Dr. Pei-Yung Lam.
Hello, I'm Dr. Pei-Yung Lam. I'm a co-medical director of the Provincial Specialized Eating Disorders Program at BC Children's, and I'm an adolescent medicine physician working primarily in eating disorders. Should I introduce Julia or go ahead with, oh, there she is.
And I'm Dr. Julia Wong. I'm Dr. Lam's co-director and partner in crime. I primarily last year was working in eating disorders, but I'm returning to some of my other clinic duties now as well. And I think Vicky, oh no, sorry, Michelle, you're next.
Hi there, my name is Michelle Horn. I am a program manager at BC Children's Hospital. So I'm a program manager with the Health Promotion and Health Literacy team, which includes the Kelty Mental Health Resource Center and the Kelty Eating Disorders website.
I think I'm the last one. Hi, my name is Dr. Vicki Clausen, and it's great to be here. I'm a family physician I work at the secondary level for eating disorders. I've been at Richmond at that eating disorder clinic for the last 15 years and at the Vancouver clinic for the last 5 years. And I also do some work in addiction medicine, that's my other hat, and some sexual assault work as well. Thank you.
Thank you, Vicky. So I think I'm going to start and I will share my screen. Here we go. So the title of my presentation is In the Shadow of the Pandemic. And it is shamelessly plagiarized from a grand rounds that was done earlier in the year at BC Children's Hospital, jointly delivered by a team from the clinical teaching unit, as well as some members of our team and the child protection unit. And it really is focusing on the unintended impacts of the COVID-19 response on children. Just before I continue, I have no conflicts of interest to declare. The objectives that I have today are to review the unintended local and global impacts of the response to COVID-19 on patients with an eating disorder, to look at some of the trends in patients with eating disorders in British Columbia during the pandemic, and also specifically to review the recommendations for care of the patient with an eating disorder as outlined by the Canadian Consensus Panel recommendations that were released in 2020. And a small disclaimer, again, as repeated from Susan earlier, is that other eating disorders like ARFID and its specific treatments will not be discussed in detail, but will be passingly referred to. And as Susan said, we would welcome any feedback, and if you require a whole separate session, a whole separate webinar on ARFID, we would be more than happy to do that. So I think where we're at in COVID is these are some statistics that have come out with regards to the impact of COVID-19 on pediatric deaths. When the pandemic was initially announced and the lockdowns, et cetera, occurred in May, the panel on the left looks at the number of pediatric deaths from March to July. And as you can see, compared to adult deaths, it's not that much. And on the right, the American Academy of Pediatrics released data in April of this year, confirming that children made up 0.00 to 0.19% of all COVID-19 deaths. And these are US states that are reporting that 0 to 0.03% of all child COVID-19 cases resulted in deaths. So deaths are not really the issue in pediatric COVID cases. However, in those pediatric deaths that have occurred, what we know the data says is that they are most often of a non-white background. So Hispanic, American Indian, Asian, Black non-Hispanic, white non-Hispanic is very low. And of these non-white deaths, almost a third died at home or in the emergency department. So we know that pediatric deaths for COVID-19, the majority of these are in the non-white population in America. We also know that because of the pandemic and the lockdowns, that vaccinations have been coming down. And you can see that in this slide here, which shows the number of doses of non-influenza and measles containing doses coming down as well. And then we start to see these particular headlines coming out in the papers. Surge in child abuse, abuse of babies up by a fifth, a disturbing trend in babies with severe head injuries during the second wave of COVID, and that was January 29th of this year. And we also see other headlines, eating disorders among teens and adults surge during pandemic. Perfect storm, anxiety could be making eating disorders worse. Sick kids, record high numbers. UK pediatricians see rise in eating disorders during pandemic. And we know our colleagues at Sick Kids have told us that the wait time there has doubled during the pandemic, with a 30% increase in their admissions of children with eating disorders to the Sick Kids Hospital in Toronto. At CHEO, we've been told that there's been a 63% increase in inpatient admissions of eating disorders. And in London, there's been 250% increase in cases compared to 2019. So this is data that I've received from a friend of mine who works in Melbourne, Australia at the Royal Children's Hospital. They've also experienced this increase in eating disorder presentations to their hospital, with new diagnoses going up and the number of admitted patients doubling from 2017 to now. So what's been happening in British Columbia? We've seen very similar trends. The blue bar is the number of new diagnoses, and the left panel shows the average number of new diagnoses and hospitalizations for anorexia and atypical anorexia nervosa between 2015 and 2020. And the right column shows the number of admissions we have had and new diagnoses that we have had from March to November only of 2020. So we definitely have a significant amount of increase in the number of new diagnoses, which is the blue bar. And there's definitely more cases hospitalized within the first week of assessment compared to the pre-COVID period. So what is contributing to the rise in eating disorders? The NEDIC helpline has identified 4 themes in the calls that they have received during the pandemic. The calls have really focused around a lack of access to treatment, patients and families saying that the symptoms are worsening, patients feeling and families feeling out of control, and patients and families asking for more support. They've also noted that family dynamics have been disrupted, routines have been disrupted, school has been disrupted, their social circles are completely different, and in many cases, parental employment and finances are completely disrupted as well. And all of these have a role to play. Specifically, this is a different way of looking at it, that there is an increased risk with increased media exposure, because if you're not going to school, you're online. Daily activities are disrupted, more social isolation, physical activity and sleep is all different. There's fear and anxiety with regards to contagion. Then without the access to care and protective effect of social supports and treatment and care, this causes an increase in eating disorder risk and symptoms. So in 2020, the CIHR commissioned a consensus panel to create some guidelines and recommendations with regards to virtual and in-person care. And this report can be found at this particular web link that is in here. And I think these presentations will be available to everyone after. So the link is available there. And I recommend that you read the lay summary report because it's the shortest and the most effective. For children and adolescents, the only strong recommendation that came out in this report by Jennifer Couturier was that in-person medical evaluation when necessary would be the strongest recommendation of all, would be the number one practice point, I would say. There were other recommendations, but they were all weak, and those included telehealth family-based treatment, online guided parental self-help for family-based treatment, virtual parent meal support training, moderated online caregiver forums and support groups. All these were classified as weak recommendations. I'm also going to stray from my lane a little and give a summary of the evidence for emerging adults, and I'm assuming that this means the ages of 18 up to about 25. They had better evidence there in that there were strong recommendations for CBT-based virtual group therapy, strong evidence for internet CBT-based guided self-help, and strong evidence for the internet-based Maudsley model of anorexia treatment for adults, or the MANTRA. Some other weak recommendations were telehealth relapse prevention and unguided caregiver psychosocial self-help. Guided parental self-help CBTE was also strongly recommended, but for caregivers and not for the patient. So this study focused, as I said previously, on the virtual delivery of eating disorders care. And it recognized that this pandemic has created a demand for virtual delivery, particularly for children and adolescents. Telemedicine in eating disorder treatment includes video conferencing, telephone services, email, text messaging, smartphone applications, and guided and unguided self-help programs. They also added a cautionary note with regards to the delivery of virtual care, in that healthcare providers need to prepare for remote monitoring challenges. They need to address privacy concerns. Weighing while seeing a patient virtually just is very tricky, and full family engagement during sessions can also at times be tricky. So this has led to those strong recommendations for children and adolescents to be seen in person. So which leads me to some of my practice points that I would like people to take home. I would strongly recommend seeing children and adolescents in person regularly, weekly if possible, especially if they're deteriorating. In particular, note that if their heart rates are less than 45, systolic blood pressure less than 85, or diastolic blood pressure less than 45, or there's a presence of any blood work abnormality, that they should be sent to the emergency department locally. I would also recommend blood work 1 to 2 times every 1 to 2 weeks, especially if purging or laxative use is a feature. I also would strongly recommend that the physician communicates with the therapist, if one is connected, very, very regularly, because the therapist cannot do their therapy without the vital information of what the weight trend is and what the level of medical stability for the young person is. I also want to note that these criteria for going to the ER and for seeing RFID and for seeing RFID patients applies equally, because the medical instability criteria doesn't matter if you are if you have anorexia nervosa or if you have RFID. These are the same medical criteria for presentation to the emergency department. In terms of getting weights done in person, it's preferable to weigh the young person in 1 layer of clothing with no shoes on. I often do not show or discuss the weight with the young person, but would prefer to give the weight to the parents. I also would strongly recommend, again, giving the weight and the vital signs trends to the therapist, because that may form part of their therapy, where they discuss the weight and the weight trend with the young person and the family. All vitals done must be orthostatic. It is also important particularly for family practitioners who may have seen this young person as they've been growing up, to visualize changes physically. It's easier to see what's happening with a young person's body once all of the layers of clothing are removed. You can also see self-harm marks, burn marks, or any bruising. You can also use this opportunity to check peripheral circulation and blood flow. With summer coming, this should be a lot easier, and it would be highly unusual to see a young person in the height of summer wearing several layers of jackets and clothing, etc. And I would want them removed so that you can look for these signs of self-harm. So a very, very quick word on resources. In 2018, the Eating Disorders Toolkit for Primary Care Practitioners was created. As you can see, it was in collaboration with a whole group of practitioners working in eating disorders in all the various regions. I would highly encourage practitioners to look at that. And also, there's a self-learning tool as well that's available to upskill yourself in the management of eating disorders. I also wanted to very quickly say, without stealing Michelle Horn's thunder, that the Kelty Mental Health website is a great resource, and it can help you look up helpful things like the secondary eating disorder program in your area. And the Kelty Center is also a helpful resource to look for private therapy resources in your area. And of course, Compass is incredibly important as well. So I'll leave those details to Michelle. I just would like to end my section by talking about some recommendations from the Fraser Mustard Institute for Human Development at the University of Toronto. I think what's been very clear to us in pediatrics is that policy solutions need to be considered so that when healthcare policies are made for the good of the community, we need to mitigate its impact on children. We need to be informed by the current knowledge of COVID-19 as much as we can, and we need to care for the most vulnerable in our community. We need to look at risk and protective factors at the level of the individual, the family, the community, and society, as well as provide multi-sectoral, child-specific coordinated responses for child welfare, education, health, food security, and shelter. Overall, we need to promote strengthening of family and caregiving environments, even without a pandemic, but especially more so during a pandemic. And that is the end of my presentation. I'm going to hand over to Dr. Julia Wong now to talk about ongoing management.
All right, thank you very much, Taeyoung. So I'd just like to thank the team at BC Children's for contributing, and whether they know it or not, to this presentation. By the end of the presentation, hopefully we will have outlined the psychosocial components to a biopsychosocial approach to eating disorders. Dr. Lam has presented on the biological components. We're going to cover a very brief introduction to an emotion coaching approach for eating disorders that we use at Children's. And again, we do an emotion coaching parent group that's spread out over 6 to 8 weeks, depending on how we're doing it. So this is just a taste, but very relevant to how all of us can interact with not only the patients and their families, but supporting each other in this marathon treatment. And then we'll finish up with a brief review of medications used in eating disorders at BC Children's. As has been outlined, today's talk is mainly directed at anorexia nervosa, some of the bulimia. The others listed below are not the focus of the talk, but certainly could have presentations on their own. So when I first meet with families, usually when we're doing the feedback at the end, I've pilfered an analogy that one of our social workers shared with me very early on about the tangled rope of recovery. And as you can see, there are so many different trajectories that someone's journey with an eating disorder can take. And the most complicated ones it can be so frustrating because one of the first questions families usually ask is, when are they going to get better? How long is this going to take? And none of us have a crystal ball. And it is a marathon, not a sprint. And the patient's readiness for change is really a key catalyst to recovery. We talk about what we try to do is set the environment up so that when that shift happens, when the door opens where they're ready to make some sort of change, it's easy for them to reach out and we're there to catch them. The other frustrating thing is we never know where we are on that tangled rope of recovery. And it's important to know that when it feels like we're going back to the beginning, that might be the last tangle before they are more seamlessly moving along towards recovery. So as I mentioned, the other thing we try to do is manage the expectations while at the same time trying to balance it with some hope. I've written down containing the container, which in talking with people yesterday I came up with, and it doesn't sound very nice, and it certainly draws from the psychodynamic roots of psychiatry. I feel though it's so important because as Dr. Lam was talking about in her presentation, it's important that policies take into mind the effect on children. We also know from the evidence that when parents are doing well and when other adults are doing well, the kids have, the mental health correlates. And I think during COVID, what we've really seen in mental health, not just eating disorders, is as parents' capacity and their mental health gets challenged by all the stress, it has a corresponding effect on their kids. So how do parents get contained? And that term, it draws from the psychodynamic view of people will, in therapy, bring their emotions all chaotic and tangled. And then as the therapist, you sit with it, you help contain it, and you hand it back to them in a more manageable way. So I find this helpful to think of when I'm receiving, and I'm on the receiving end of a lot of emotion and frustration. And I also am aware of community members, school faculty, other healthcare providers, how we need to do that for each other. And I certainly have team members that will do it for me here. We sometimes say that is why we have such a big team, because when parents are losing hope, we hold the hope for them. When we are losing hope, we have team members who hold the hope for us. And generally speaking, we don't all lose hope at the same time. So that's helpful. The other thing that I think this year has really emphasized is while compassion fatigue, burnout, all of that is a real thing, and certainly self-care is a real thing, it runs the risk of blaming the victim and feeling like, well, I just didn't take care of myself well enough, and that's why I'm feeling so stressed and don't know how to manage other people's emotions, how to manage my patients, how to manage the families. It's the same for the parents. So finding a way to compassionately talk about what can they do to create more space so that they're able to be present and accompany their child in the journey of the treatment would be really helpful. Sometimes that means they get their own therapist. Sometimes it means they visit their family doctor and they get on medication. The options are endless. One of the concepts that I've really found helpful as well have been articulated in a book called Burnout by Dr. Emily and Amelia Nagowski. And they really talk about separating the stress from the stressor. And in life, we're not going to get rid of all the stressors, and we don't want to. They're important. We have a tendency to think if we could just remove the stressor, we're not going to have stress anymore. That isn't the case because we need to move through the stress. And when we get stuck, and in cases of trauma, this is often what happens, the stress overwhelms us and we can't move through it fast enough as the stressors keep piling on. Throughout all of this, I think it's important to remember that the reason why we are caring for these patients and why we're working with the families is that we do care. And all of this is grounded in love. And I was reminded by this by a patient recently who had a review panel. And she said to the review panel, I know my team is doing this because they really care about me. And when they put me in restraints or when they give me intramuscular injections, it's because they really believe I need it. And so even though she is so sick and she is in one of her sickest times, it was really reinforcing to know that she recognized sometimes treatment is hard and it requires us to be in the moment and not putting our emotions aside for a short time and revisiting them later. So in the approach to treatment, we think of the parents as the first line team members, and it is crucial that we collaborate with them to create a vision for care and what they feel able to do. The concept of energy in, energy out is something we share with patients and families. In eating disorders, specifically in anorexia, energy in has to be higher than energy out. How to get there? There's different ways to look at it. And the more they're willing to decrease their energy out, perhaps we may be able to reduce a little bit the overwhelming energy in that they feel they're being faced with. As Dr. Lamb noted, it is so crucial to do the medical monitoring, the following of trends, both medically and with weight, and for that to be communicated to the therapist. Because the therapist is speaking with the person who has the eating disorder and is sometimes speaking with the eating disorder. The eating disorder rarely tells the truth. We also know that the body doesn't always correlate with the actions. So sometimes they may be taking more in. And so if the family and the patient is with the therapist, they may be saying, yeah, we're completing everything, we're doing everything we're supposed to. But if the therapist doesn't know the weight is going down, they're not going to be able to support them to do even more. One of the dietitians emphasized and said, just make sure you really emphasize, we need to empower the parents to help create structure where energy in is the priority. And these are the things that you can do even before they get to a therapist. And it's sort of almost pre-FBT like. You're providing this foundation, helping set the stage for when they are able to get engaged more with therapy. When engaging the patient themselves, we always try to find common goals. It can be very tricky to do that. Rarely by the time they get to the tertiary center are they agreeing that health is a common goal, but sometimes they do. Sometimes we can engage them around, we all agree, we want to help keep you out of hospital. There's one patient we have who said, I have no desire to recover. I have no desire to talk about eating more. I have no desire to work with you guys. So the common goal I engaged with her around was, okay, you know what? I want what you want in terms of fewer appointments. I agree. Obviously, yes, my long-term goal for you is health. We're going to dial it back. And what I want for you right now is let's work towards fewer appointments. And again, we come back to that concept of how can we do that? Well, can you do more energy in or can we decrease the energy out? Our dietitians here in the tertiary program, Jadine Cairns, Judy Larenman, Diana Dickinson, phenomenal dietitians who I often say they're dietitian therapists. And they talk about the food pyramid. Before they see a therapist and when they're really trending down, the priority is the foundation of adequacy. It doesn't matter what they're eating. It doesn't matter if it's solids, if it's meal replacement, liquids. They just need to get enough in to stay medically stable. All the other things are more advanced on their journey of recovery, and some of them may not be targeted during their time with the child program. In terms of decreasing energy out, it can be really powerful when patients realize that both the family and the team are not prioritizing anything over their health. So achievements, tests, competitions, dance competitions, it's very, very powerful when the adults in their life say, you are more important than your activities, than your accomplishments, and we are going to help you with that. That may mean they can't go to school. That may mean they do virtual school, or it may mean they need a cognitive rest and they need to take a break. It might mean that they miss an important soccer game. It might mean that they really don't get to go for walks. Maybe they're going in a wheelchair. Maybe they're going for a drive in the car with the window down. One of the challenges we have when this happens is that, understandably, people wonder, well, if I take all of this away, their mental health is going to crash. This is another diagram that I'll often draw for parents and patients at the beginning. and it helps manage the expectations. When they come to us, their mental health is not great, but it's okay. And their weight is down low. Once in hospital, for the majority of patients, certainly not all of them, we're not bad at getting the nutrition in and the weight up. But as that happens, mental health drops because the eating disorder starts beating them up for gaining weight. And so the mental health is going to deteriorate. Patients and families will sometimes say, you told me that my brain wasn't working and that I needed more nutrition, and it would start to work when I got more nutrition. And now the eating disorder is worse than ever. And the reality is the eating disorder is as smart as the person who has it. And when the brain gets nourished, the eating disorder also gets more energy. So they do feel worse often as the weight is going on. Treatment factors to consider. It's a real challenge to balance their developmental stage. In many ways, how they're being treated is a regression from their chronological age and going back to meal support like when they were in elementary school. Autonomy versus paternalism, very hot topic in ethics, and we actually involve ethics not infrequently in our program here to try and balance the treatment goals, because paternalism is often needed. As I was going over this presentation, I was reminded of a young patient a number of years ago who, after the assessment, she was medically unstable, and we had to tell her she was being certified and she was going over to the medical unit. And she was sobbing, begging her mother to take her home, which is part of the reason we certified and didn't use a voluntary admission. And then security knocked on the door, and I went to answer the door, and she grabbed my arm and she said, "So you're not giving me a choice?" And I said, "I'm really sorry. No, we need to do this." And she said, "So I have no choice. You're going to make me eat." And I said, "Yes." And then she started to sob harder and said, thank you for saving my life." Now, it took 3 years of her in our program. She did graduate out of the program, and it was the first step in a very, very long journey. But it's that example of, it is hard in medicine, and sometimes we have to be paternalistic. If we can look for other opportunities to provide developmentally appropriate independence, that is always helpful. Factors to consider regarding treatment and how much families are going to push. It's the relationship with caregivers. Treating eating disorders is a strain on the relationship with parents. So one of the reasons we're going to touch on the emotion coaching is because we know that the emotion coaching and managing our own emotions and helping to meet their emotional needs creates space, reduces anxiety, and allows the relationship with parents to challenge the eating disorder identity. Safety issues, violence in the home, so active suicidality as well, those are somewhat contraindications to family-based therapy and may lead towards more of the secondary and tertiary services. So again, just like Dr. Lam, I haven't managed to get these resources to Michelle, but Dr. Delle LaFrance has done a lot of work with emotion coaching specifically for eating disorders, and we have drawn on her work as well as work of many of our other social workers and psychologists in our program around emotion coaching. So the top half of this tree, and this has been taken from Dr. LaFrance's website, the behaviors you see, denial, avoidance, criticism, they can remove the focus on what the emotion is that's driving these behaviors. What is the child trying to alleviate in order to get rid of those emotions listed below the surface? They're engaging in actions that they have learned in the past, and maybe when they were very young, that worked, that aren't particularly functional now, but from an eating disorder point of view, get them what they think they want and need. By meeting the needs of the emotions below the surface, below the ground, we can show them that perhaps they don't need to do these other behaviors and develop their repertoire for other coping strategies and engage in some collaborative problem solving. The principles of EFFT focus on viewing the emotion as a wave. It has a beginning, a middle, and an end. Every emotion has a trigger, whether it's conscious or unconscious. And the emotion is specific and can be named. The emotion also comes with feelings in the body and creates a need for that emotion, and a action tendency, which in this terminology tends to be something that we don't really want, but the child is doing to get their needs met. This is where we also have an opportunity to meet the need in a different way, where we focus on what is the need of the emotion versus focusing on the behavior. In times of calm on either side of the emotion, if there has been a rupture, if there's an opportunity for repair, this is where we can do that. It's also in times of calm where we would engage around collaborative problem solving so that both parties get their needs met. This can be done for both positive and negative emotions. We do in medicine tend to focus on the negative one, so that's what we'll be focusing on moving forward. The good news is that in the emotion cycle, half of the cycle is in our sphere of influence. And this draws on family systems theory and other things like that, where if you could make a change in one part of the system, it will have a ripple out effect in the other part of the system. Validation is a key component in emotion coaching and in eating disorders. So paying attention to what the child is feeling, name it to tame it, slow things down to allow mindful responses so you're not just reacting straight away. Convey your understanding of the feelings, the urges, and you demonstrate that through becauses. So I can appreciate that you're really angry right now because we're admitting you to hospital without a choice, because you're going to have to eat or you're going to get the NG tube, and because you had plans to go and celebrate your birthday tomorrow with your friends. You can do less, but apparently 3 is optimal for your brain overloads. Emotional support is provided with presence through comfort, connection, space, reassurance. And then once the emotion has been recognized, most people will feel like if you practice this with other people, you'll notice that often there'll be a calming in your nervous system when you feel like someone really attunes and connects with you. Sometimes the practical support is then not needed, or the problem solving, because it's really something you can't problem solve, or there may be opportunity to do that. If you can't problem solve, redirection is sometimes helpful. So in anxiety, often redirection is a key component of strategies for coping. And at other times, engaging in problem solving is helpful. I'm not going to go through this in detail. This is something to refer back to, but it has that concept of, if you name the emotion correctly, it will allow you to identify and empathize with what they might be feeling physically. It will help identify what the need is and what the less functional coping mechanism they're motivated to do. And then consider how to meet the need of the emotion rather than focusing on the behavior through validation and other factors. In past years, what inpatient youth have told us was helpful from a staff perspective was when in the program the structure was kept. Reminders of rules when necessary, often in a general rather than pointing any individual person out. Distractions, and so in meal support, when there used to be meal support in the kitchen prior to COVID, always there would be games that would be played, and conversation to just normalize meal times in a very abnormal setting. For the family, they're encouraged to eat together, play games, have a conversation, don't stare, don't talk about food, which can be really challenging for a lot of the siblings. And so it is often, okay, well, part of the FBT, there's a reason why they do a family meal, because they see how the family system works and help problem solve and support everyone else in learning a new way to support and eat meals. In the parent group, we specifically apply emotion coaching to meal support, and it has been shown to reduce anxiety. reducing the anxiety, as we've mentioned before, creates a space for motivation to engage in recovery, to grow. When we make mistakes, when we do something that is hurtful and that we wish were different, apology has been shown to improve relationship, and it's a whole topic of one of the groups in emotion coaching, the therapeutic apology. We know that improved relationship with parents challenges the eating disorder identity, and yet we know, paradoxically, that we have to encourage parents to set limits and boundaries and become more intrusive in the meal support. We also know, and we start off the emotion coaching parent group by talking about this is a group for you. It's actually not specifically about your child. And it's because we know that when we can manage our own emotions, it leads to more effective use of functional coping strategies and emotion coaching strategies with others, and utilization of the meal support strategies, because you're in a more calm, contained space to do that. I'm not going to go through this one again. It's for your reference. They're just tips on what you may want to consider going through with families to help them problem solve how to support during meals. And again, this was taken directly from our parent group with the, at least with the graphics. Humor is always good, and it's very weird on Zoom because you have no idea how the jokes are falling. But choice is stressful. We know for kids, predictability, structure, organization can reduce anxiety. That doesn't mean complete rigidity and no choice. It's more, though, knowing what comes next and knowing where the limits are. Over and over again, we have patients who at times will say, even when it comes to this certification discussion, when they get to our site, I can't be responsible for choosing to stay in hospital. You need to take that away from me. Potential ways to decrease stress outside of hospital are having them less involved with shopping, cooking, serving, decreasing, removing choice responsibility. And again, going back to what patients say they want, maybe what the eating disorder wants. The healthy part of them.
Excuse me, Julie, Bruce is poking me to make sure I give you the 2-minute warning. We want to just make sure we're keeping on the schedule. Thank you, sorry.
To make sure that you know who you're talking to when you're making the decisions. Post-meal can be a very stressful time. For some people, the worst time is before meals, some is during, some is after. Regarding medications, I've specifically not given dosing here because it is so individual and case dependent. What I would encourage you to do is, if you do want to start medication and you're unsure, please call the BC Children's Compass line for support, and we will be able to help with those decisions and guiding dosing. The bottom line is, like, what are we trying to treat? For how long are we going to treat them for? And that will help guide whether or not you're going to use benzos that might lead to tolerance and dependence issues, whether you're going to go straight to antipsychotics. Are there comorbid psychiatric disorders that need to be addressed? There is no medication that will cure an eating disorder. Again, here's just some of the things that we consider when we're deciding what to use. And you will be getting all of these slides. And I wanted to just finish by thanking everyone, not only who work with the eating disorder population, but just in mental health right now and overall in the medical system. We empathize and we feel along with you the fatigue and the frustration because of the severity of the patient's illness, because of the situation with resources, and because ultimately we just want to help and get these kids better. We wish there was more help for everyone. So thank you for joining today, and we will be answering questions after Michelle's presentation.
Great. Well, thank you so much, everyone, for inviting me to speak today. I'm just going to share my presentation here. Okay, so as mentioned at the beginning, I'm Michelle Horn. I'm a program manager with BC Children's Hospital. I oversee the Kelty Mental Health Resource Center, as well as the websites that fall under the Kelty Center. So I guess just to start, I thought I would start with this infographic, which was created by the Provincial Eating Disorders Network and showcases 3 organizations that provide prevention and early intervention services and supports in BC, as well as programs for individuals at all stages of recovery. So these 3 organizations are Jesse's Legacy, the Looking Glass Foundation for Eating Disorders, and Kelty Eating Disorders. As mentioned, I'm with the BC Children's Kelty Centre, of which the Kelty Eating Disorders website is a part of. So I can speak mostly to that, but we'll also briefly touch on the great work being done by the other organizations here. Okay, so the first one is Jesse's Legacy, which is a program of Family Services of the North Shore. Jesse's Legacy provides eating disorders prevention, education, resources, and support for BC youth, families, educators, and health professionals. There's lots of resources on their site for parents and caregivers, and also parents or individuals can email or call Jesse's Legacy with questions they may have. Jesse's Legacy is also the lead for the Provincial Eating Disorders Awareness Campaign, also known as PETA. So the second service program that was in that infographic is the Looking Glass Foundation, which is a nonprofit foundation that supports individuals aged 14 or older at all stages of recovery. So they offer many resources on their website, support with service navigation, and also peer support. They actually have 3 different peer support programs. So they offer peer support offered both on a one-to-one basis, as well as in small groups, as well as peer support for caregivers. And there's no clinical diagnosis or referrals required to access their services. So the third program that was in that infographic is Kelty Eating Disorders. So the Kelty Eating Disorders website is one of 2 websites that sits under the Kelty Mental Health Resource Center. The other website isn't specific to eating disorders. It's keltymentalhealth.ca. It's our more general website. It does have information and resources on a wide array of mental health topics for parents and caregivers, but this one here is specific to eating disorders. So on this website here, there's a number of free eating disorder resources, as well as support with service navigation for parents and caregivers. Here you'll find general information on types of eating disorders, treatment options that goes through different types of therapy and treatment options that are evidence-based, as well as a finding help section, which Dr. Lam mentioned in her presentation, where you can go in and find an interactive map, type in where you live in BC, and see listings of all the eating disorder services in your community. So the website also has a fairly robust section focused on recovery. I just wanted to highlight that section because there's some really great resources and videos and fact sheets that you can find there, developed with the Provincial Eating Disorders Program at BC Children's. This includes videos and supplementary fact sheets on meal support for parents and caregivers, with subtitled versions in a number of languages, including traditional and simplified Chinese, Punjabi, French, and Korean. These are really helpful videos. You can find a whole video that provides a comprehensive overview, or you can find it broken up into 6 different chapters with different aspects of meal support covered under each. I also just wanted to touch very briefly on what the Kelty Centre offers. So we provide peer support, information, and resources for a variety of mental health and substance use challenges, including eating disorders. We support families in understanding and connecting to treatment options and support services in their communities. We're available for anyone across BC. We have a toll-free phone number that parents or caregivers can call. They can email us, or we can provide support through Zoom video call. And we don't have any wait times. There's no referral required. And then more specific to peer support in eating disorders. So we do have 3 trained parent peer support workers that work at the Kelty Centre through a collaboration with FamilySmart. And these peer support workers offer non-judgmental, compassionate support to parents, caregivers concerned about their child or youth. We know for a lot of parents, just being able to connect with another parent who's been there, whose child has been in a similar situation or who has had similar struggles, is a great weight lifted off their shoulder, and can really help them to access those services or their supports if they were hesitant to access them, and really just feel kind of less alone and less stressed in the situation they're in. And I just wanted to note that we have seen an increase through the Kelty Centre in the number of contacts related to eating disorders since COVID began. So just a few additional resources for parents and caregivers that I wanted to mention. So one is a website called CanPed. So it's www.canped.ca. This is run by CHIO. And it has a number of educational videos on a variety of topics, including what eating disorders are, understanding the medical risks associated with eating disorders, treatment options for youth, the highs and lows of supporting a loved one, and meal support, so before, during, and after meals, which includes the Kelty Center videos within that section. Another one I wanted to mention, the Kelty Center has a podcast called Where You Are, and we did one episode a little while ago. It was called When Parenting Gets Tough, How to Support Your Kids When They're Struggling. It was with Dr. Ashley Miller, who's a child psychiatrist at BC Children's Hospital. You can see the link there. And I wanted to mention this one. It's the episode wasn't specific to eating disorders, but it really nicely touches on a lot of the things that Dr. Wong was talking about in her presentation. So Dr. Miller and a parent are on that episode. The parent actually is a parent of a youth who has an eating disorder, and we have a conversation with them about what does validation look like? What does validating your child's feelings look like? What is actual language that parents can use in that situation? What is the therapeutic apology? The parent actually goes through her experience of doing that with her child, and how awkward it was at first, but then how it really helped. So that might be really helpful to let parents know about. It's often just so helpful to hear from another parent in their voice, having gone through this. And then finally, a book called Help Your Teenager Beat an Eating Disorder by Locke and LaGrange. And you can find the link there, and I can send out this presentation afterwards as well. So just a few resources for healthcare providers. So this Eating Disorders Toolkit, Dr. Lam already mentioned that one in her presentation, so I'll skip over that one. And finally, I wanted to just highlight this educational opportunity for physicians as well. There's a 2-hour online course that was developed by members of the Provincial Eating Disorders Network and the BC Eating Disorders Community of Practice. It sits on the Provincial Health Services Authority Learning Hub site, but anyone in BC can create a free account and access this course. You don't need to be a PHSA employee or anything like that. So this course aligns with the clinical practice guidelines for the BC Eating Disorders Continuum of Services. And learners that take the course will be able to understand the core content and principles from these clinical practice guidelines, summarize the function of an eating disorder and its impact on individuals and their families, understand the differences between various feeding and eating disorders, and identify the differences between levels of care for treatment. So it's one that I'd encourage you to check out. And that is it for me. Thank you so much.
Thank you, Michelle. I'm just going to ask all of the panelists if they could please turn their videos on, and we'll move. Of course, I'm having problems turning my own video on, but we'll move to the question and answer part. Okay, I can't turn my video on, but that's okay. So thank you very much to the audience for submitting questions. We've got 22 questions posted, and we'll try to get through as many as we can in the time. And thank you very much to all three of the presenters for really excellent comprehensive presentations. So our first question, many youth with eating disorders are not diagnosed until their physical health has significantly deteriorated and their parents seek acute care. What suggestions do you have for earlier intervention and diagnosis which could lead to better outcomes? And I was thinking, Vicki, as someone who sees some of these patients before they get to tertiary services, you would be a great person to answer this question.
Hi. So I don't have a formal presentation, but I'm happy to talk about my experiences. Yeah, that one's a difficult one. Oftentimes the school counselor might have some insight into what's going on at the school. And I just want to acknowledge, I actually do some work in the high schools in East Vancouver. And I acknowledge that's kind of all come to a bit of a shift in the last year since COVID started. You know, over a year ago, I'd go into the high schools every week and talk to kids around disordered eating, not necessarily them having a diagnosable eating disorder, but counselors would say, oh, I have this kid who, you know, we've noticed that they're not eating with their friends, or, you know, they're maybe a bit more distracted in school, or they're not eating their lunch or whatever. So that is still a great way to get some information. So, you know, right now I acknowledge that it is a little bit more trickier because not a lot of kids are in school for the whole day. But that has been a great resource where I would get information from school counselors or teachers for that matter. You know, a change so for parents, just if they notice like some changes in, you know, the child not eating with them at dinner anymore, or there's a change in food preferences, like becoming vegetarian or vegan, which doesn't align with the rest of the family. I find that can be an earlier sign too. Changing of grades. Yeah, so those are some earlier signs. I think that is important for parents to watch out for. You know, losing for girls, irregular periods, or losing a period for 1 or 2 months is a bit of a red flag too earlier on. And you know, of course, people think with stress and that kind of thing that's pretty normal. But if it's just for something to watch out for, especially if there's a change in food habits and that kind of thing. Sorry, I don't want to take too much. I could talk forever and I'm going to stop.
Thanks, Vicki. I just wanted to add also that I think if you're a family practitioner, particularly if you've known a young person for a long time, as is the case with a lot of family practitioners, sometimes your spidey sense goes off and you just know something's not right, particularly in the area of food and intake. There is a free questionnaire that you can administer. It's called the SCOFF. S stands for, do you make yourself sick because you feel uncomfortably full? So the S is for sick. C is for, do you worry about losing control over how much you eat? O is for, have you recently lost more than 1 stone? This is a British questionnaire, so 1 stone in a 3-month period. The F is, do you believe yourself to be fat when others say that you're too thin? And the other F is, would you say food dominates your life? So SCOFF, you can Google it, it's free. It's very well validated in terms of like, if you get a yes to 1 or more of these questions, then your spidey sense is correct.
And it's also on the pathways. So if you go to the pathways, it's one of the questionnaires that they've got there.
Yeah.
Okay, thank you. Our next question, what are best practice recommendations for clients or patients sitting on wait lists for months waiting for services? And Julia, I'll put that question to you.
So the best practices are the points I think we tried to reinforce. Follow their weight in person, look for the trends, look at the guidelines that Dr. Lam gave, and encourage the families to eat with the child more, get a sense of what they really are eating and completing. Have a healthy curiosity and don't take things at surface value. It may be monitoring more what they're viewing on social media, what websites they're looking up. And if you have a scale in the home, because I think that's a later question, hide the scale. And just to draw on the emotion coaching part again, begin to really do anything you can to connect with them, spend time with them. Right now, in particular, COVID, social emotional needs are hard for teens to get met. And for sure, they don't want it from their parents, but looking for ways to have those needs met in creative ways and building the relationship to meet them whenever you can.
Thank you. Payung, I think the next question is for you. What are your red flags for investigations for referral to the eating disorders program and for sending to the emergency room?
So I'm going to go backwards in terms of answering that question. The criteria for sending someone to the emergency department are, number one, if the heart rate is below 45. Number two, the systolic blood pressure is below 85. Diastolic blood pressure is below 45. If there are any abnormalities in the blood work, or if the ECG has a heart rate that's below 45, I think those are criteria that would make me send someone to the emergency department. That's the medical criteria. If someone is suicidal, or if they have active plans for suicide, I think they deserve to go to the emergency department to be assessed to see what's contributing to that. In terms of investigations, we have a panel of investigations that we would recommend to make sure that we're not missing any other conditions that could be mimicking anorexia nervosa. So for example, hyperthyroidism, inflammatory bowel disease. So it's good to exclude some of these with, say, a CBC, an ESR, ferritin level, looking for inflammation, etc., looking at renal function, and then also electrolytes to check for potassium and glucose levels, because if they're purging or using laxatives a lot, it's very important to check those electrolytes on a regular basis. And if the potassium is below 3.5 or 3, I would send them to the ER. If the glucose is below 3, I would send them to the ER. Vicky, would you agree?
Yes, I was going to comment on the random glucose, especially for people who are restricting their intake. Sometimes for people who are really struggling with restriction, I'll do that every week. You know, there was a time when we gave out a glucometer. I don't think that's actually useful for families. I just think that gets them into this over medicalization at home. So yes, the random glucose for sure. And I think that's really all I wanted to add to that. I do often talk with families about what that means if their glucose is low in terms of their liver glycogen and those kind of things. And long-term stuff, we think about doing a bone density, but that's if they haven't had a period for, you know, about a year or over 6 months, that kind of thing.
I think if someone...
I'm just gonna move us on to the next question, just because we want to try to get through as many as possible. Julia, what wording do you use when addressing the distorted body image? How do you convince a youth that they are underweight when they truly don't see it?
This is an excellent question. And there's no standard way to do this, because it really depends on knowing the patient and how best they respond to different things. We do use a lot of euphemisms, but then there are certain patients who really want the direct approach, and we will use a direct approach. We use the term health. We use the term stability. We'll use, sorry, can we put the question back up? Oh, probably not, never mind. And what we really try to do is not get into an argument and trying to force them to see something. So the emotion coaching approach, and maybe I did not want to role play emotion coaching without some of my emotion coaching partners, but one of the things we would do is, well, yeah, you're getting really frustrated with us because we keep talking about your need to have more nutrition and gain weight. And I can understand why you'd be really frustrated about that, because you really don't think it's a problem. You think that we're kind of making a mountain out of a molehill. It's really not a big deal. And we're taking up, like, you're having to come to the hospital all the time for appointments when you would rather be doing a lot of other things. So right there, I've identified the emotion. I've conveyed my understanding with the 3 becauses of why they are frustrated and angry with us. And yet I've not agreed that they don't have a problem. And then we go into, you know, I understand that you don't think it's important, Yet from a medical perspective and from an ethical perspective as a doctor, I cannot let this go unchecked. This is what we need to do. Is there any way we could balance, like we could understand what's really getting in the way of you being able to get to this place, which medically all these people say you need to get to, like what's getting in the way? And then sometimes you can get to the root. If they're an athlete, it can be a little bit easier because sometimes you can tie it to performance and sometimes they tend to respond a little more to authority figures. So it's a more coachable moment of, if you really don't have a problem with this, you'll be able to do what we're asking you to do. Now, we all know that if they're really not able to do it, there is an underlying eating disorder. I think, like anything, none of us do very well when someone approaches us with the intent to change our mind. So keeping that in mind, thinking of the emotion coaching principles and really trying to understand and validate the emotion of where they're at without validating the behavior.
I'm just going to riff off something that you said about coaches and all of that, because there is a question later on in Slido about performance and athletes and so on. I find in that situation, engaging the coach, getting permission from the parent to talk to the coach about the medical issues and be transparent about what's going on can be sometimes really, really helpful. Because ultimately, a good coach wants the best performance out of their athlete. And you can't get a good performance if the kid is not medically well enough to give you that good performance. So I think engaging coaches, and some coaches are better than others, I will admit, but trying to engage the coach in that discussion is really helpful.
And a really good coach prioritizes their health over performance.
Thank you. Next question. Vicki, this one will be for you. Are there resources on how to deal with skeptical parents? I have 2 patients whose very thin mothers think their kids are just eating clean and look great, even though they are less than 3rd percentile for BMI and meet the criteria for severe disease.
Well, I want to start to say that this is hard. This is not easy, and I don't have like a magical solution, and probably Dr. Wong or Dr. Lam might have some other suggestions, but honestly, sometimes I do medicalize things a little bit for the family. Like when at the secondary level, when I see a family and if, you know, there's a lowish random glucose, or if there's a couple periods that are missed, or if there's like even a flattening of the growth curve, you know, it doesn't even have to, you know, cross growth curves. I'm talking about just like a flattening of the growth curve. I'll sometimes explain to the family like what that means in terms of their potential growth and their bone health and that kind of stuff. So I often go that way in terms of trying to bring the family on board. I know Dr. Wong has more a bit of a psychosocial approach to it, but that's kind of how I bring in families. Or even if the child is describing some gut bloating, like gut disturbances, I'll kind of go in from a medical piece on that. And 2, like talking about gut health, and gut is a muscle and we need to, you know, and we have to care for it like a muscle. So I try to go for it from a more of a for my practice, and more of a at the family medicine level, from a more of a symptomology level. That's how I try to bring in families. Yeah, that's what I do. I use the growth charts a lot, actually.
I think visual aids are really important. Being able to actually visually show things and investigation results and sharing those with the families is what I would do too. Yeah.
Great, thank you. Next question is for Michelle. I'm finding it difficult to find supports for teens who don't want their parents to know their diagnosis and thus don't have money for counseling, etc. Vancouver Coastal Eating Disorders programs have a huge wait list. What can we offer these patients?
Yeah, that's a good question. I mean, you can always contact the Kelty Center and we'd be able to, depending on where you are in the province, connect you to local services and resources. For youth, Boundary Virtual is a great option. So youth can connect with one-to-one counselors as well as youth peer support workers through Boundary Virtual with limited or no wait lists. Or they can connect with 1-800-KIDS help phone if they were looking to connect with a counselor right away.
Thank you. Next question, I think we've answered part of it, but not the second part. So I will go ahead and pose it to the panel. Should we be recommending to parents to not have a scale at home? And if so, how do we monitor our at-risk preteens that rarely come into the office?
Can I take this one?
Please.
Okay. It's not as easy as a yes or no, because I think that there are some parents who, in conjunction with the therapist, can safely have a scale at home that they keep and they hide and they keep it locked up and away and so on. And it can be useful in helping monitor trends. But that's a very small minority, though, of parents. I think by and large, having a scale in the house, the kid's going to find it. They're going to break in somewhere and they're going to get the scale and they're going to weigh themselves. So I actually would prefer that the scale is not at home. The weights are usually done depending on the type of therapy the kid is having. If it's family-based therapy, our family-based therapists like to weigh the kids themselves. And so the weighing gets done in an environment. And in terms of, and this is again the reason why I think that kids need to be seen in person in the office. And even if they come in for a quick weight and vitals check and then duck out again, it just takes 5 minutes to do, or 10 minutes to do all of that. And yeah, I would really recommend that they come into the office.
Just really quickly too, it can be, if at all possible, training the person who's going to be doing those weights, so it doesn't take much time, but using the same scale and doing them blinded and having them in a similar set of clothing, because you're trying to standardize it as much as possible.
So we're going to try to get through as few more quick questions before we have to close. So I could ask the panelists to please give some short responses. Next, Vicki, what are your recommendations for GPs, as they are often the first access point for parents worried about possible eating disorders in their children?
So I'll try to be quick. I would just say, echo what Dr. Lamb said, try to get them in, try to maybe develop like seeing them at least once a month, get the family or a loved one involved early on, I think is also really important. Those are probably the most key things in terms of just bringing them in often and like, you know, encouragement. I've switched, well, I've always been encouraging, but like I've done more and more encouragement in the last year than ever, I feel like, on the secondary and family doctor level. I'm trying to give encouragement all around to both parents and children. So encouragement, seeing them often in person, and getting the loved ones involved early are my key recommendations.
Thank you. Julia, what are common triggers or personality profiles of eating disorder patients? How common is physical or mental abuse a factor?
So for traditionally, binge, purge, bulimia has been associated with borderline personality traits, and obsessive compulsive personality traits have been associated with anorexia. I think I would just reinforce that statistics are helpful to prod you to ask questions, but every patient is an individual. And we know that eating disorders when people have eating disorders for long enough, they look borderline. And when the eating disorder resolves, those symptoms resolve. Even for some of the most entrenched patients you would have thought for sure would have borderline PD until they were 50. Physical or mental abuse, I think that, again, for sure, they can be components, it needs to be screened for, but like any form of trauma, it's going to be patient-led, and they're going to need to have a good relationship, and they're going to decide how much they're going to disclose, and you may not know. What we tend to say is you do not need to know the origin of the eating disorder in order to recover from it. It's so much more intellectually satisfying to understand how it developed, but you really don't need to know that in order to treat it. For sure, if it was active mental and physical abuse, you'd want to intervene. So that's also part of the screening. And my brain doesn't remember statistics, so I'm sorry, I have no idea on the actual numbers.
Thank you. So we've got time for one last question. And I think, Pei-Young, I will send this one your way. So amidst COVID-19, eating disorders are often comorbid with other mental health and psychosocial factors. While in hospital, what would you recommend regarding expectations for schoolwork, stress management, etc., for the healthcare professionals, for the patient, and for the parents?
So thank you. This is a very common question that I get asked by family doctors and pediatricians, actually. It's like, how much activity, how much schoolwork can they do? I think immediately, well, whilst they're in hospital, I try to say no schoolwork, because your brain needs to rest and your cognitive function needs to recover. When they leave hospital, I use the analogy of, you've just recovered from a major injury. You don't go out there and run a marathon right now. You actually need to rest and you need to recuperate. Your body needs to rest. So I go for a graduated approach, of graduated return to school, return to activity approach, very, very gradual. I talk about developing other interests and using this as an opportunity to find out what else rocks your boat. So this might be the time that you find out you really like photography, or you really like crocheting, or you really like making paper cranes. This is the opportunity for you to try different things.
Great, thank you. So we have reached the end of our time for questions and answers, and I apologize that we haven't gotten through all the questions. I believe, Bruce can direct us, but I believe there will be a mechanism for the panel to respond and send out those responses for the questions we weren't able to get to live. Just before I turn it back over to Bruce, I would like to ask the panelists if they could please give us one key message that they would like the audience to leave with today. And maybe Pei-Young, I'll ask you first. We can go in the order of the speakers, and Vicky with you at the end.
Thanks. Because I go first, I get to say this. I'm going to say, please see them in person. Nothing replaces a visual and in-person blood pressure, heart rate, orthostatic vitals, and a visual look at how well or unwell the young person is. So please see them in person.
Great. Julia.
Remember that you don't have to be perfect in delivering the care, and that the connection with the patient and the family will go a really long way.
Excellent point. Michelle.
Yeah, I guess I'll take this opportunity just to give a shout out to peer support and how valuable it is. It has really been shown to reduce stigma. Folks are more likely to seek services. It helps facilitate early intervention and access to services. So both parent and youth peer support is incredibly valuable for parents and youth.
And Vicky.
I just want to say there's no magic solution, and it's hard. Know when to send a patient to the hospital, see them often. I'm reiterating what Dr. Lamb said, and just give tons of encouragement and just be kind.
Excellent. Thank you very much to the panelists, and thank you very much to the audience for joining us this evening. And I'm going to turn it back over to Bruce, who is going to wrap things up for us.
Thank you, Susan. And I'm sure to the audience, as with I am really sure you'd love to continue hearing more from this incredible panel. But we've reached 90 minutes and it's time to wrap up the webinar. So I'd really like to express my sincere gratitude to all of you, to the panels, Drs. Julia Wong, Pei-Yung Lam, Dr. Michelle Horn, and Dr. Vicky Klassen. You're all very dedicated healthcare professionals and we're excellent panelists. Thank you for taking your time for your very busy lives and heavy responsibilities to present and answer as many of the audience's questions tonight as we could. I'm really sure that everybody has appreciated it. I really also wanted to acknowledge our hardworking UBC staff, without whom the delivery of these webinars would not be possible. So a special thanks and shout out to Stephanie Amio, Desiree Torrios, Haresh Gindwani, and Erica Chaplin, as well as our leadership team of Catherine Young, Bob Blumen, and Jenny Barrows and Brenna Lynn. And finally, I just wanted to thank all of you for attending and hope that this session was of value. Please take a few moments right now to complete the attendance and evaluation forms that were emailed you in order to obtain study credits and to be able to provide your feedback on tonight's webinar. And please note that this webinar is accredited for up to 1.5 Main Pro Plus or Section 1 credits. And finally, I wanted to let you know that about our other free webinars that we're offering in our COVID-19 webinar series over the next few weeks. April 15th is dealing with the hidden epidemic of alcohol use disorder with Drs. Sophie Waterman, Julius Elefante, and Paxton Bach, with Dr. Christy Newton moderating. That's tomorrow night. May 12th is an expert Q&A with public health, vaccine, epidemiology, and lab specialists with Rekha Gustafson, Mark Lissishin, Manish Sedarangani, Mel Krajden, and Nomi Mate with Dr. Simon Moore moderating. And then finally, on June 16th is another youth substance disorder with Drs. Haley Brooker, Steve Mathias, Caroline Sari, Tom Warshawski, and David Smith. And please be aware that you'll be receiving a follow-up email containing tonight's webinar recording and links to all the resources that were mentioned tonight by all these great panelists. So thank you again, everybody. Really appreciate your time and the panelists' time. And thank you to all and good night. Take care.